All right. Good evening, everyone. Thank you so much for joining our cardiovascular health webinar this evening. My name is Mandy Scott, and I am this year's Vice President on the Ontario Kinesiology Association Board of Directors. One housekeeping item before we get started. We're using Zoom's webinar feature, so none of your videos are visible, but if you have any questions, please feel free to put them in the question and answer box, and we'll address them after the presentation is complete. I'll introduce our two speakers this evening. So we've got Dr. Matthias Hausen, who's a postdoctoral fellow at the University of Ottawa Heart Institute, supported by the Jan and Ian Craig Cardiac Prevention and Rehabilitation Endowed Fellowship. With a background in exercise physiology, his research focuses on cardiac rehab participation, social and gender factors, and tailored exercise programs for people who are living with cardiovascular disease. He brings clinical, academic, and Olympic level experience from Brazil. With us, we also have Dr. Ariane Vieira, who is a CIHR Health System Impact Fellow and postdoctoral fellow at the University of Ottawa Heart Institute as well. A physiotherapist by training, her research centers on improving patient-centered cardiac rehab through alternative assessments, exercise modalities, and behavior change strategies. She has extensive experience in multidisciplinary interventions and evidence synthesis. And with that, I will turn it over to you both.
Thank you. Thank you, Mandy, for this introduction. And I'd like to wish you all good evening. Thank you so much, the Ontario Kinesiology Association, for having us here this evening to talk about a topic that is of great interest to us. So, as she just mentioned, we are postdoctoral fellows, and this is the type of topic that we explore in our research as well. So we're going to be happy to share today some information related to prescribing aerobic exercise training to patients with cardiovascular disease. And today we will give some introduction about cardiac rehab and exercise training for this population. So what are the benefits of exercise training and the importance of exercise training for this population? What also are the available tools for us to prescribe the exercise and to do the monitoring during the training? And this includes different tools that we're going to be mentioning. Also, the recommendations for patients with cardiovascular disease in general. So general recommendations, but also the specificities for different conditions, including like peripheral artery disease or heart failure. And the use of technology in aerobic training prescription that is very relevant, especially nowadays and, after the COVID-19 pandemic. So we thought about like sharing some research that our lab also had developed. So to start, as you may know, like cardiovascular disease refer to a group of disorders that include the heart and also the blood vessels. And these include conditions such as coronary artery disease, heart failure, and arrhythmias. So coronary artery disease is the most common type of cardiovascular disease and is the one that is mostly related to myocardial infarction with the appearance of arteriosclerosis or atherosclerosis. And in general, cardiovascular disease are the leading cause of death globally and is responsible for over 17 million deaths per year. And over here on this like infographic, you can see below that there are like some risk factors just highlighted and listed there. You may know already, right? Like high blood pressure, the people living with obesity, smoking, diabetes, they are also all related to the occurrence of cardiovascular disease. So, and one of them is actually physical inactivity, which is very, very important for us. And then cardiac rehab. So cardiac rehab is a multi-component intervention, which includes different components, different factors that are going to help these people with cardiovascular disease to gain quality of life, to deal with their chronic disease, to gain, exercise capacity and have their lives improved. And it can also be for preventive cardiac rehab. So we also have patients in cardiac rehab that have those risk factors that I was mentioning. Sometimes they don't have cardiovascular disease or official diagnosis, but they have as well some of those risk factors. So the components of cardiac rehab include, smoke cessation, exercise training, drug optimization, blood pressure control, counseling, patient education. They are all represented here with these icons. And cardiac rehab is actually a class 1 recommendation. So what does that mean? So class 1 recommendation means that there is a consensus on the literature and evidence of research that makes us strongly encourage and recommend, the associations strongly recommend cardiac rehab, especially for people with chronic coronary syndrome. And this cardiac rehab can really help them achieving a health lifestyle, managing those risk factors, and prevent the reoccurrence of the disease. So cardiac rehab has been shown to reduce cardiovascular mortality and also hospital admissions and improve the quality of life for coronary heart disease. So, but when we talk about exercise training specifically, so exercise training is one of the main components of cardiac rehab. As you can see here, like we have some steps that include patient assessment, the delivery mode, and also all those components of cardiac rehab. And today we're going to focus on the exercise training aspect and specifically the aerobic training. And here I'm just showing as well that the evidence on the literature shows to us some improvements for people in short, medium, and long term. And those benefits of exercise training include the reduction of mortality or a large reduction in cardiovascular mortality. For heart failure, it has shown to improve all-cause mortality in long term. It also decreases the risk of myocardial infarction, so major reduction for both short and long term. And as well for short term, we have strong evidence for reducing hospitalizations and also improvements in quality of life. So exercise training, as you know, it can bring so many benefits for health and also cardiovascular disease patients. And these benefits include cardiac benefits and also systemic benefits. So it can increase cardiac outputs, the stroke volume, it decreases ischemic injury or ischemic events. It helps the vascular function, including our endothelial health. And overall, it increases our aerobic capacity. So the aerobic capacity, I want to highlight here because it's also related to mortality, and it's one of the most common or more explored outcome of cardiac rehab because it's very important. So as I was saying that aerobic capacity is related to mortality, and these studies show to us that higher cardiorespiratory fitness is inversely related to mortality risk for people with and without cardiovascular disease. So on this study, they actually used data from more than 90,000 people in the US, and they did an exercise test or a cardiopulmonary exercise test in different time points, and they were evaluating them like the risk of mortality and the exercise capacity of these people using the METs, the metabolic equivalents. So we see in the graph that the relative risk of that it decreases if our peak exercise capacity or our peak metabolic equivalent increases. So this is a very nice graph that shows that this is actually true for both health people and people with CVD. And also on the same study here, so again, more than 90,000 people from the US, it shows also the difference when we have different levels of cardiorespiratory fitness. So there is a progressive decline in mortality risk associated with an increase in cardiorespiratory fitness, but also an increase in risk. So we have more risk of that when we decrease our exercise capacity. And the difference here, this graph, it is for people only with cardiovascular disease, but the difference here is that they took for the graph at the top people that are least fit or have a lower exercise capacity, lower cardiorespiratory fitness, and the one below is moderate fitness. So for all levels of cardiorespiratory fitness, it's the increasing in our meds it's related to decrease in mortality. And then exercise training is really like a protective factor against the appearance of chronic disease and also reduce the risk of death from cardiovascular disease and is the main component of cardiac rehab programs. And when we mention exercise training and prescription, it's important to say that this prescription needs to be tailored and needs to be individualized. So, although we have like general recommendations, we need to assess patients and do a patient assessment before prescribing exercise. And also, we say sometimes that like it's a it's a treatment, right? Like exercise is something that we use for treatment of these patients. So as any other treatment, there is a specific dose, there is a specific quantity of exercise, volume of exercise that can be beneficial. We don't want to like to prescribe anything that can be harmful, but also not anything that is might not be beneficial for this population. So one principle that you probably know already is the FIT principle for prescribing exercise. So it needs to have a specific frequency, intensity, type, and time or duration. And also we nowadays we talk about the V at the end, with this is the volume. And intensity is actually the one that we explore the most because there are so many different ways and different tools that we can use to prescribe and calculate the intensity of exercise. And these tools include different exercise tests from like maximal tests, submaximal tests, or field tests, and then prediction equations and subjective parameters. So I'm gonna just show you some of these tools here. If I'm not mistaken, I believe OCA has some tools available on the website as well, like on evidence uh, page over there that you can find some of these assessment methods. So I won't go over details, but it's important to say that the most common or the more recommended, the highly recommended exercise test is actually the graded exercise test. It is also known by exercise stress test or the cardiopulmonary exercise test. The difference is that for the cardiopulmonary, we have the use of the mask, as you can see in the picture. So like the use of the gas analysis, breath by breath. And this test is very important for different purposes. It's used for diagnosing heart conditions, also to understand the appearance of arrhythmias, to evaluate exercise capacity, assess treatment efficacy, to guide return to activity. Also, it can be used to stratify the risk of the patient. So once we do this test, we are able to gather lots of variables and information from how the body, how this person is answering to a stress, to an exercise test. So some of these variables include heart rate, blood pressure. So we're gonna measure how those variables are answering, like how they are responding to the intensity of exercise, and also how they recover after we are finishing the test. We can observe as well electrocardiogram changes. So this test is also used to diagnose ischemia or appearance of ischemic disorders, and also respiratory and metabolic variables that include, respiratory and metabolic rate, respiratory exchange rates, volumes, and ventilatory thresholds. So very useful information also for exercise prescription. Functional and performance variables. And by that, I mean the exercise duration, the metabolic equivalent that I was telling you about before, the power output, and also symptoms. So it's important this test because we will understand if the person has angina, dyspnea, the saturation of oxygen as well levels. So all of these type of variables are delivered driven from this test, and actually most of the guidelines and the associations that recommend exercise for cardiovascular disease patients, they recommend this test strongly for assessing these patients. But the difficulties is that not every time this test is available, not all patients will have access to it. And in that case, we have tests that can be an alternative. So only like as a necessary alternative, we will have different tests. And that include the 6 minute walk test. So this one, it's usually done in a corridor, like a space of 30 meters. Can be 15 meters as well. It was adapted for that too. And we ask patients to walk as far as possible. So they have to do the longest distance that they can. So not more fast, but actually the longest distance and cover more turns. And we will measure the distance that they walked, and also we will be monitoring some of the variables as heart rate, as the rate of perceived exertion as well. And the 6 minutes walk test, it's very used on the context of cardiac rehab. And then we also have the incremental shuttle walk test. So for all of these, there are like a few guidelines and few tools available that you can search in case you want to practice and in case you want to be able, if you are not able yet, to apply the test, to be trained to apply the test on your patients or clients. And so the incremental shuttle walk test, some people argue that is a greater cardiovascular overload because for this one, people can actually run. So it can be actually a maximal test as well. And then we have the talk test, which is assessing the level of comfort of speech, which has been shown to be related to the ventilatory thresholds of the cardiopulmonary exercise test. So it's high correlation with the reference test, and it's also more accessible and low cost because we might not need like the whole setup as we do for the graded exercise test. And then when we're gonna monitor the exercise test, because it's not only assessing that and then prescribing based on our patient assessment, but also we need to understand if the participant is doing the exercise in the appropriate intensity. And the scale, the Borg scale for rate of perceived exertion, is the most common tool that is used. On the Heart Institute, we use the original one that is from 6 to 20. And the moderate intensity that is usually recommended for cardiovascular disease patients is 12 to 13. And that means that it's some effort, is somewhat hard. Speaking is still possible, but a bit difficult. And then we use the heart rate as well. And nowadays it's even easier because we don't need to teach. I mean, it's also super helpful and it should be also done like teaching people how to measure their heart rate. Of course, it's useful, but nowadays we have, those monitors and those some options that are even cheaper as well. So it's becoming more accessible and available. And then we can make sure that the person is exercising the target heart rate zone that is recommended for them. So it's an individualized prescription. And that is only not recommended in the case of arrhythmia. So let's say in the case of atrial fibrillation, we then don't use heart rate. We can use as a variable, but it's not the target monitoring variable, and we use then power output. And again, the talk test, which is a simple tool that is also available for assessing like how hard the person is exercising. So let's say if the person is exercising a level that I can only say a few words. So I say a word and then I need to, take a few breaths and I say another word. This might be, it's related to vigorous exercise intensity. So it might be not the exercise intensity that we are aiming for this person. So it's also a simple tool that is available. It's again, it requires maybe some training, some practice for the individual to have their own perception accurate. Um, but it should be fairly um, available and accessible. And here I will just share like some general recommendations for patients with cardiovascular disease. And this is very general, as I was saying, and at least 3 days a week is what is recommended for aerobic training. But if more can be done, it's better. So it's preferably 6 to 7 days a week. The intensity should be from 40 to 59 of the VO2 max or VO2 peak in case of this population, and 60 to 74% of the heart rate reserve, and the duration minimal of 150 minutes per week, but it also could be adapted to calculate the volume. So depending on the intensity of the exercise, it could be less, it could require less time during each week. So continuous or interval-based training, in addition to resistance training. So we are not focused here on resistance, but that would also be relevant and important to make sure we structure the prescription. And there are several expected outcomes, and these include the level of aerobic fitness that should be improved, the overall coordination, flexibility, range of motion, endurance, and reduced fatigue. Also, some reduction on symptoms, attenuate response to physical challenge, improved psychosocial well-being, and decrease in cardiovascular risk and improvement in prognosis. So some of those outcomes uh, are commonly reported to us in the cardiac rehab setting by the patients and also showed on the literature. So now we will go for the specificities of exercise prescription. So what should we take care, like what we should be looking into when we prescribe exercise for patients with other conditions and for adults with congenital heart disease. So in this case, as you may know, congenital heart disease is like a malformation of the heart that is present since the birth. And some types of congenital heart disease, they are actually mild, and some other can actually cause life-threatening complications. So it's important to understand what is the condition of each patient and do the patient assessment carefully. And some advances in diagnosis and also in treatment in the last years, have really improved the survival for both, for those that are born with a heart problem. And here there is just a differentiation between people that had a defect with no symptoms early in their life, but they actually present symptoms later on, and they might need them treatment and a procedure. And also we have those that actually presented already symptoms in a complex defect that was repaired during their childhood. But the thing is that these symptoms may return years after the congenital heart disease defect is treated. So different cases, but still it can be like an atrial septal defect, can be a ventricular one. And as I was mentioning, it could be mild or it could be more life-threatening. And it's interesting to say that patients with this condition are often asymptomatic. And in case they have symptoms, those symptoms include, fatigue, angina, and it can also, it needs to be further investigated because it's also similar to symptoms that we see, for example, in atrial fibrillation or other types of arrhythmias. So in this case, because patients are often asymptomatic, it's very important to do an assessment of both subjective and objective exercise capacity. So again, the importance of the cardiopulmonary exercise testing to assess the VO2 and monitor for adverse response to exercise. But again, if this test is not available, but is highly recommended, it could be a graded or stress test done. Here is just like a algorithm or like a flow chart kind of thing that shows that the risk classification is very important for these patients. So understanding what is their conditions to then understand what is the intense that we should prescribe for them. So this is related to this risk classification as well, and the risk classification can be performed by the clinician alongside with all other, allied healthcare professionals, and it requires to understand also the ventricular function, the aorta, the pulmonary, if there is pulmonary hypertension or not, how is the functional of the valves, and if there is any arrhythmia related to the condition as well, for them to understand what is the recommended exercise intensity for this population. In regards to intensity, duration, uh, and frequency, it's similar to the general for patients with cardiovascular disease. But again, the risk stratification is important here, and doing the patient assessment in details to understand the patient's conditions and where to start from. And again, it can vary, so it can start from a low risk. The patient can present greater symptoms afterwards. So every like 3 to 6 months is important to be doing the patient assessment, and again to assess the conditions of the patient to reevaluate our prescription. I think with that, I will pass through to my colleague Mateus. I hope I was not going too fast.
Thank you, Ariane. I just want to confirm you are seeing my screen now.
I am. Yes, all good.
Amazing. So I'm continue. So thank you very much. So getting into heart failure details. So first, heart failure is a reduced ability of the heart to pump and out with blood, and it's considered a heterogeneous syndrome, and it's life-limiting with the progression of the disease, chronic fatigue, dyspnea, and exercise intolerance, leading to a reduced functional capacity and decreased quality of life. Around the world, it's estimated that affects around 26 million people with a prevalence of 1 to 3% of the overall population. And this increases around 10% with those aged 70 or older. In Canada, it's estimated to have 3/4 of a million living with heart failure currently. And regarding exercise for this population, it's known the reduction of hospitalization with patients with heart failure for those who are engaged in exercise structured programs in cardiac rehabilitation, leading to a lower 24% odds of mortality compared to a control group, shorter hospital total time, and a lower incidence of readmission in a month period. There is strong evidence suggesting the benefit of exercise training for classes 1 to 3 of the New York Heart Association criteria for this population. And it's well established improvements of quality of life, cardiorespiratory function, and physical activity participation, active lifestyle. And some of the benefits of exercise for a person with heart failure includes muscle effects like muscle hypertrophy, increasing oxidative phosphorylation and calcium enhancement, vascular effects such as increase in capillary vessel formation, reduction in aortic stiffness, and increase in compliance. Respiratory effects like increase in vital capacity, tidal volume, and peak oxygen uptake. Neurohumoral effects like reduction of sympathetic tone, reduction of several hormones like BNP, angiotensin 2, and noradrenaline. Cardiac effects like increase of left ventricle ejection fraction and a decrease of the left ventricular and diastolic diameter, and preventing arrhythmia, diastolic function, and other effects. And finally, hematological effects like reduction coagulability and blood viscosity. Sorry. And across the world, we have several recommendations and guidelines for exercise training, like the Australian, European, American, and from Scotland. They all agree that exercise in a moderate intensity with a stable condition can improve the exercise capacity, quality of life, uh, and of course needs to be supervised at first place and then moving progressively to a more simple program. And in terms of cardiac rehabilitation, as well put by my colleague Ariani, we have different recommendations, like the European, the American one, and the English one, and they all have the same consensus that it still can be considered in patients with higher level of disease, and depending on the priority, but done with the tailored approach in several precautions as well established by all those recommendations that can be found in the work done by Divin. And in terms of again the caution about how to conduct those programs in terms of supervision and risk management, high risk patients need a closer follow up in the early phases, and the supervised cardiac rehab is ideal in this scenario. And gradually, as I said before, the addition of non-supervised, simpler home-based sessions are recommended, not simple in terms of course, there are a lot of tailoring and uh, recommendations, but in a lesser degree of control than the previous. And overall, it offers a low risk, even high intensity with all the appropriate methodology. And even in severe heart failure patients, there are ways to do this inappropriate, of course, with the correct tailoring. Moving forward, exercise sessions should be individually tailored for several weeks, first with maximum exercise capacity, as well put by Dr. Vieira as well, in terms of using the cardiopulmonary exercise test to use those outcomes not just for prognosis, but also to tailor the sessions. It can also use by the monitoring of the heart rate response and the close monitoring of symptoms, like preventing any progression with the compensation, like the presence of arrhythmias, edema monitoring, and especially in patients with atrial fibrillation, we need to be careful to use the heart rate. So it's more recommended to use the power output, let's say the speed, the percentage of peak speed, or the peak, let's say the speed or the bike output compared from the thresholds, like the anaerobic thresholds or talk test thresholds, but using power based or rate of specific exertion instead of heart rate. And finally, bringing the one of the most respected guidelines, the European Society of Cardiology suggestion for this population. The ideal frequency would be allowed 3 to 5 days per week, optimally daily. The intensity around 40 to 80% of VO2 peak, and a duration from 20 to 60 minutes per session. In terms of mode, as well said by Ariane as well, it can be both continuous or interval-based training. And the progression should follow a progressive increase and with frequent follow-ups around 3 to 6 months, and adjusting duration and intensity based on patient tolerance, which is really important. One of the key factors of any exercise program, supervised, home-based, is about patient's adherence. So if it's a pleasant exercise session, of course, not easy, hard intensity can be a little bit harder, but it needs to be feasible so patient can engage and persist working on the expected design sessions. So it's important to always be careful, be mindful, be very in terms of sensitive of patients' tape tolerance. Now move a little bit to another group, the peripheral artery disease group. It's characterized as a complex pathophysiology, including restricted arterial flow, endothelial dysfunction, inflammation, muscle structural and metabolic abnormalities, causing a high risk of ischemic limb symptoms such as attempted claudication, amputation, and mortality. Of course, it leads to a poor quality of life and impact daily activities, the functional capacity. Worldwide, it's estimated that affects 23.6 million people. And in Canada, it's estimated around 2 million Canadians living with peripheral artery disease currently. And unfortunately, despite this high number, patients are usually underdiagnosed, undertreated, and also underserved with suboptimal management of the condition. And the supervised exercise program are first-line therapies for these groups, especially those who are experiencing the intermittent claudication. And again, as I said before, we have robust evidence and still is not being transferred to actual care, so they are heavily underserved. And of course, this impact on the quality of life is mainly caused by increased blood viscosity, the thickness, compromised blood flow and oxygen extraction, skeletal muscle fiber changes that favor anaerobic metabolism and can tolerate shorter uh, shorter exercise, short movement, skeletal muscle weakness, and inefficient walking gait. So those are the targets of the exercise programs that can actually be adjusted and improved to impact their life positively. Walking, the modality, the type of exercise, the walking should be the core component of these programs. Stair climbing can also be considered, but it needs to be careful in terms of the patient's tolerance. Other non-weight bearing aerobic activities can be considered as well, like cycling or upper body ergometry. But again, it doesn't replace walking and can be used complementary. And the main one of the main aims, of course, is reducing complication like pain that affects patients' lifestyle overall. And in addition, we have comorbidities, of course. So the presence of diabetes and hypertension also needs to be accounted. So it needs to be managed before starting a new exercise program. And there's a specific recommendation, very important, with patients with peripheral neuropathy, that they have the less sensitivity on the lower limb. So it's important to check the feet regularly and recommend the use of adequate protective footwear. Firstly, participation should begin clinical and or professionally supervised with both the close look in terms of the disease and then the the tolerance of the imposed load, but it can be transitioned to a more self-guided independent program when patients increase their fitness in terms of like fivefold the metabolic equivalent or twice the job demand. There is an important index that needs also to be understood in the when working with peripheral artery disease, which is the ankle brachial pressure index scale that can be helpful to classify the peripheral artery disease. And there's also a post-exercise in, measurement as well that can help with additional diagnostic value and can be tracked across the program to adjust the load and conduct to the best correction for the program. In addition, we have the claudication scale that's really like course totally. It's the main like very very important for this group. And as I said before, with the clinical professional supervision, the close look in terms of the claudication scale will anchor the intensity of those sessions. So I'm bringing another guideline from the American College of Sports Medicine for this population, and they suggest a frequency of a minimum 3 days per week, preferably 5 days would be even better. The intensity have three possibilities, like a moderate intensity from the oxygen uptake reserve between 40 to 59%, or we can anchor using the claudication scale in a level between 3 to 4. So we need to prioritize working in a longer interval within the 3 to 4 level. It's preferable than trying the maximal in the 5. So it's more recommended to use this. It's very important to make sure the session, each walking sprint, like a walking interval, needs to be like in this sub-maximal level, not the maximal level of pain. Or the walking speed itself can be used the percentage between 50 to 80%. The duration, it's recommended to be between 30 to 40 minutes per day of exercise, so excluding the pause moments. And the activities, as I said before, aerobic activity like weight bearing in terms of can be like treadmill, free walking, and secondly can admit also the ergometry in parallel. And the intermittent walking protocol is best recommended, like walking until the moderate pain, as I said before, and the rest in between the walking sets needs to be in a sitting position to make sure the pain is completely gone to restart a new walking round. And in terms of progression, it's recommended to use a total duration with a minimum of 12 weeks, with a progression up to 60 minutes per day. And this additional recommendation from this book from McDermott also suggests exercise programs in 3 situations. So supervised treadmill exercise, home-based walking exercise, and ergometry bike-based exercise. So they have a frequency between 2 to 5 times per week, and now they have like similar duration, and you can find the details in the reference below. But it's also an interesting resource to guide possible different uh, types of program. And now moving forward to the last topic of our talk, how can you use the technology to improve the quality of the exercise prescription and also the adherence? As we said before, it's not just important to bring the best methodology in terms of load, precision, accuracy, tailoring, but again, we need to make sure that the patient is motivated, is enjoying somehow. Of course, we know that's not easy to work in many of those conditions, but still they need to have something that pushes them to complete the program with a minimal like motivation, enjoyment, to make sure they can adhere and take this active lifestyle across their lives. So this study from our group that I'm happy to collaborate, we gathered like many reference across several cardiovascular conditions and what has been done so far with technology to improve not just prescription but other topics as well that I will go into. So we have available now, of course, with time, the accessibility, the prices have become more accessible for those commercial devices. We need to be careful in terms of selecting the brands, selecting the quality, but we have now reliable brands that are committed with validation in their lab. They have specialized exercise physiology labs so they can validate properly the metrics they are selling within their devices. So we have like classic accelerometers, but now smartphones, smartwatches, chest straps, anklet monitors can help with prescription for those populations. The first function would be like baseline and follow-up assessment. So we can have like additional metrics or even evaluating patients, clients from a distance in a telemetric way. So now this distance can be shortened with technology. So we can have like periodical and easy, like not just in terms of, oh, we have a feature that measures this certain technology, but we have be careful also with usability. So now we have devices with a very intuitive, user-friendly layout design, so patients from many ages that doesn't require a high level of technology literacy. They can easily measure step count, movement minutes. So now it's become like not just cheaper but easier to measure a lot of useful metrics. As I said, physical activity and behavioral goals can be easily measured, not just in terms of measuring it, but also educating patients how, so they can see by their devices how it works, how it fluctuates across the week, how week different from another, so they can also be educated in active lifestyle as well. Again, now back to physiology. Now with continuous heart rate in an easy way, not you don't even need to hit, you just put the wrist, you have heart rate pumping easily from the screen, so patients can easily follow, understand how the sessions affect their body, and they can follow the training zones provided. I saw a question about the beta blocker, so I can advance from here. So one of the suggestions is if we have patients using beta blockers and we want to use heart rate zones, what we usually suggest in exercise physiology labs or clinical facilities with the CPAP routine, we ask patients to stay in the same situation they will be training. So if they're training under beta block usage, we ask them to continue the beta blocker in the CPAP so they can match the same range. In terms of engagement, education, and self-efficacy, we now have the possibility of have like notifications, badges, a lot of motivation strategies by several apps, and also is a way of communication. So we can send resources, dissemination papers, or interesting videos, or PDFs. We can easily exchange information with patients or clients. And least, like last but not least, flagging and disease management. So we know that the arrhythmia monitoring of those devices is developing quickly. They are always now validating increasingly with clinical gold standard devices. So it's important that can inform, and we have like some reports on the news of people that have been like saved by notification. They went straight to a doctor and they have the proper care on time. But on the other hand, we need to be careful because the excess of information and the without the proper preparation of patients, some tests, some flagging, some notifications can be actually stressful. So we need to educate patients how to use and how to have some criteria when uh, receiving those notifications from their devices. So we need to be careful as well to adjust this expectation. And finally, we have some quick recommendations per cardiovascular disease. Like for atrial fibrillation, the use of smartwatches can be helpful for detecting irregular pulses, but as I said before, accuracy may vary, so we need to be very careful for this population when using, let's say, a wristband. We need to educate patients and make sure it's a validated device. But on the other hand, we can use more like movement devices like pedometers, accelerometers. They are more reliable for this population. And for patients with the usage of cardiac implantable electronic devices, heart rate monitors, and the phones that can also communicate with the heart rate straps can help patients to train within the safe zone. Like we usually set between 10 to 15 beats per minute below the equipment threshold for shocking or activating it. And there's also some evidence of the use of accelerometers again as another therapy to help like exercise behavior, active lifestyle. For coronary artery disease, we have some studies showing that both heart rate monitors, pedometers, accelerometers can provide effects on physical active levels and also cardiovascular fitness, and of course, as we know, quality of life. For peripheral artery diseases I brought before, we know we have some evidence of use of both wrist-worn and ankle-worn devices that can help with set minimal physical activity. And for heart failure, we have anklet monitors and also sensor vests that can help monitoring not just physical activity, but also peripheral edema and pulmonary fluids. So it's very important to make sure we are tracking those patients and we can flag any decompensation and pause it and reevaluate, or even actually pause the exercise and then reevaluate the patients. So I think that's now where I finish my talk. I want to thank you very much for your attention. I hope it was helpful. We can bring some insights, review some foundations of exercise prescription, and here's our emails and social media. We'll be happy to have any questions, any exchanges. And we also would like to invite you all to take a look at our work that we have been conducting at the Heart Institute. Thank you very much.
Thank you both so much. That was great. That was great. We will now turn it over to the Q&A. If there's any questions, I do see one that you did touch on about the beta blocker, so that's great. Another question, will this presentation be available? The OKA, we will be sharing this recording in a couple weeks, but as for the actual copy of the PowerPoint, I mean, if you both are okay, can we, circulate it, or what would you be your comfort level there? Sorry, directed towards the two of you. Just to clarify.
Yes, no.
Sorry, yeah.
Yeah, I think it's fine. It's fine to circulate. Yeah, if Mateus is
Yeah,
okay with that too.
yes, and also I suggest if some of those references we have in our PowerPoints, many of them like guidelines, they are open, so it's easy to be accessed by. So you can take a look on the details of the measurement that can be recommended, like concerns, specificities of subtypes of those diseases. So I think I also it's important to suggest to take a look on other reference. They are very informative, some reviews, some guidelines, a lot of good information available.
Perfect, perfect. I will leave that with Stuart at the OK office to determine how we share that. Okay, a couple more questions came in here. Are there any recommendations for individuals who are wheelchair bound?
Yes, that's a great question. Yeah, thank you for bringing that up. Um, There are, of course, it depends on doing the patient assessment and risk stratification. So it depends on the condition. But if it regards mostly for mobility, we have arm ergometers, and we do also have chair-based exercise. So this is nice, and now it's aligned to a new class that the Heart Institute is actually offering for more like frail or limited mobility patients, patients with limited mobility. And then the wheelchair, it's you could be doing like those chair exercises as well, and that it would include, TheraBands as well, or weights and stretching and doing movements, and even with the use of music sometimes can help with like aerobic exercise.
Great. Next question we have here. What are your thoughts on the CSTF step test for evaluating predictive VO2?
So I can start and then you can complete. But from my end, I think that's also it's interesting. We have some positive results in literature, like suggesting the use of the step test. As a start, I would just recommend to first see in terms of functional capacity and knee joint limitations if the step movement itself can be done by the patient without pain in terms of orthopedic aspect, like locomotion aspect. But if it's not a problem, the step movement, for sure, I would include as as an option. And it has provided good. We had some studies with step tests in the Heart Institute in past with good results.
Good.
Yeah, I agree. I would endorse as well that they use if it's available, if it is accessible, if it makes sense to the situation. It has shown, of course, it has some limitations, but I would endorse its use as well.
Good. Next one, would the guidelines on graded exercise testing be the same?
Would the guidelines be the same? So would that mean when we are performing like the exercise testing? Or using the greater exercise testing for prescription.
Well, they just added, sorry, the same for the wheelchair bound individuals.
Would the guidelines for the greater exercise test be the same? Yeah, so that's a good question for sure. So, um, would that the I don't know if the situation of a wheelchair is because of restriction mobility, if it is actually for no mobility at all in the lower limbs, If that is the case, then you cannot do cycle ergometers. Of course, it needs to be arms ergometer as well. And um, what are the tools that would be available? I know that for monitoring, of course, like we can use the rate of perceived exertion, heart rate, and the talk test. But then for performing an exercise test, I would say the arm ergometer.
Good. What signs should we look out for that would indicate an exercise is too intense for a senior heart failure patient?
Okay, so I think I can start with this one. For heart failure patients, I think important signs to monitor for in terms of the compensation of patient, not just older patients, but overall, is like a rapid gain of weight in few days, like a couple of days, new edema, resting dyspnea, and increasing fatigue like in a higher extent than expected. So I think these can help interpreting if the exercise program needs to be paused, the load needs to be adjusted, and be compensated. But of course, if the metrics provide you the train prescription zones, and then the patient is not tolerating it well, it's of course reasonable to reduce it gradually and seeing where the patients can sustain, and then again monitoring a possible new increase in future. But in terms of uh, monitoring the heart failure condition, I would rely on those I mentioned before. And in terms of exercise tolerance itself, it's all about adjusting it, like bringing it down, like see how patient evolve, and then bring it up again in a smoother progression, I would say.
Great. Great. I'll give it another minute or so if any other last minute questions come in.
I
If
will.
not, oh, go ahead, go ahead.
Sorry, man. No, please.
No, I was just going to say if any more questions come in, we can have them, we can address them now. If not, feel free to reach out to the OKA office or directly to the emails here on the
For
screen.
sure.
Yeah.
Just about the beta blockers one, I was
Yes.
going to mention that usually we use as well heart rate. I think I type or answered that. And if we were able to access, like Mateus mentioned, the patient under this condition, so it was using a beta blocker during an exercise test, would be able to access the condition and calculate the heart rate zones based on the test. Otherwise, we can do the estimation of the maximal heart rate, but then because of the beta blocker, we adjust this estimation, and sometimes it's usually lowering by 10 to 30 beats per minute. So we would decrease the maximal heart rate estimation at around like 20 beats per minute. So we can use still heart rate zones, but taking into account that condition.
Yeah, that's great. We have two more. So let's quickly do these ones and then the other ones we can address just because we're getting close to 8 o'clock here. If someone's interested in learning more about cardiac rehab or entering work in this field, where's a reputable place to certify?
Uh, we have a few like institutions that we recommend, but in Canada, I'm sure that CCPR, right, again, could be like a good, uh, like a good association to reach out to. Like they provide formation, like webinars. We have the spring conference yearly, so both of us have participated on CCPR activities. So there's a strong network here in Canada. For sure,
Yeah.
that would be my first guess.
Yes, that's the Canadian Association of Preventive and Cardiac Rehab, and they have some models. So, in case you become a member, if you want to invest and learn more about entering this field, you could become a member and access some of the models. But I don't want to like advertise a lot here because I know there are like lots of available tools that are free online as well, and the Heart Institute has some materials as well. And also, I would recommend taking a look on the ICCR, which is the International Registry for Cardiac Rehabilitation. So the registry, they also give accreditation. So they also have a program online that you could do to learn a bit more about cardiac rehab and then to get a certificate as well. So I don't have the information of how much it costs or even like if it is free, but I know they have a certification program too that might be worth taking a look.
Awesome. Okay, we'll just address this last question and then we'll close off the Q&As here. Why do you recommend weight-bearing aerobic activity over non-weight-bearing activities in those with peripheral artery disease?
Great question. Thank you. So I think we're bringing here is like the evidence of the benefits. So we have several studies showing that the walking exercise itself within that it's like strict range between 3 to 4 points of the 5 points pain scale shows great results in improving all those constraints along the metabolism and the circulation of the lower limbs, as previously mentioned. But for sure, I understand that in terms of if a patient can't tolerate in the uh, 3 to 4 pain scale score, we can also help with some implement to partially like expose patient until the patient reaches this 3 to 4 points of pain within like a reasonable walking duration, then restarting in next rounds. But I think we are bringing what's have been shown literature that that's most beneficial is trying the walking exercise, and I think it reflects also the daily activities for many patients. And again, it's a really hard condition. It's of course the painful exercise, and if at the beginning to reach this 3 to 4 non-weight bearing can be necessary in the beginning. It also can be considered because first the exercise program needs to be tailored, individualized. If for this patient, we evaluate, we use the clinical judgment, all the available evidence, and we have the conclusion that needs some non-weight bearing, like a cane, other implement that can help the patient, it can be considered. But for sure, we don't want to expose the patient to the highest level so they can sustain the minimum necessary to promote the benefits. And on the other hand, there is a need of a partial exertion. So you need to stimulate in a higher extent. So maybe a non-bearing, weight-bearing activity that doesn't reach the minimum level of 3. We also are not sure that we are close to reach the expected benefit. I don't know if you, Ariane, you have any thoughts on
No,
this too.
I agree. I agree. I think it doesn't substitute, so it's the walking is important as an exercise and weight bearing, but I think if that limits completely like the person or doing activity on a crisis, doing the activity on that specific week, or if progressing is too slow, we don't wanna the person to not do exercise and to not gain the benefits of cardiac rehab of cardiorespiratory fitness. So then it's an alternative that at least maybe can increase adherence and help gain exercise capacity.
Yeah, we want to offer the patient best stimuli, but make sure there's no risk of fall if the it's not decompensating the disease. So we need to, like, between the guidelines and the patient level, we have of course some clinical judgment, some tailoring that we get the tools from guidelines and assemble the best approach to each patient for sure. But great question, thank you.
Great. Great. Thank you both so much. And thank you everyone for your questions. Again, if you have any questions, please reach out to the OKA directly or to either Ronnie or Mateus. And yeah, with that, we'll close off the evening. Thank you all so much.
Thank you so
Thank you.
much.
Glad to
Thank you
be
for having us. Thank you everyone for their questions.